I think due to the time restrictions, I would avoid a break at this moment, and I will proceed to what I have been looking for from the beginning of the day, which is actually to confront my mentor by asking him a number of difficult questions. So I'm very happy to introduce Professor Athol Wells, who is, as we call, a sarcoidosis giant. He's the main driver of the management guidelines in European Respiratory Society, as well as internationally, I would say, by his role in providing this dichotomical approach between quality of life and danger from the disease. I would just say that I thought about this session, Athol, primarily because when I joined the Royal Brompton Hospital, you were running the difficult case clinic, where quite frequently sarcoidosis patients were attending due to the inability to manage their symptoms or to provide them with accurate prognosis. So I thought about providing this session to ask the expert about his views about the condition. Thank you for joining.
Thank you very much. I will just access my screen. This part generally establishes my IT incompetence, but can you see my screen and can you hear me?
Yep.
Very good. I will keep this short because a lot of questions dovetail with what I'm going to say. And these are very large topics, so 10 to 15 minutes. It's actually easier than an hour in a way. And I love the discussion format, by the way. So let me launch into this quickly. Core issues with diagnosis, the need for biopsy, and we've been tyrannized by expert views that sarcoidosis should always be biopsy proven. And there are certain exceptions recognized that I don't need to go into because these particular scenarios are in any case not really relevant to long-term sarcoid. The point is that in reality, we don't always biopsy. And this decision has to be a patient-doctor partnership. I will later on, because there's a question about this, spell out exactly what I mean. And I'll talk to defining how likely sarcoid is and the sort of strategies that can then be chosen by a patient and a doctor in partnership. And I'll say no more at this point. Whenever you're talking about biopsy, though, you really do have to spell out what alternative diagnoses are possible. And although you can make a list for sarcoidosis in individuals, what is realistic as an alternative diagnosis does vary greatly. So it's very patient-centered, your views on this. And all I'll say at this stage is that chronic infection can mimic sarcoidosis. This is a common trap, and tuberculosis especially. It's a very important question because you can actually have sarcoidosis and TB together at the same time. There are reasons that I could speak to why this might be the case, but that goes into pathogenesis. And then secondly, a big alternative diagnosis is malignancy, because cancers of various kinds can give rise to a sarcoidosis reaction with some features of sarcoidosis as an entity. And if you go through the list of malignancies, it's lymphoma that can be especially important. But again, I will come back, no doubt, to this later. Now, I've listened into the cardiac sarcoid and neurosarcoid sessions, which were very enjoyable. And I just want to make 2 points. In what we do, we have to bring together skills, and the term for this is multidisciplinary discussion. So in our weekly cardiac sarcoid meeting, for both diagnosis and treatment, we have 6 skills in the room. We have 3 imaging gurus dealing with the strength of heart function, echocardiography, with the amount of damage in the heart, that's MRI, and the amount of inflammation, so that's PET scanning. And then sarcoid expertise, cardiology expertise for the right treatments to support the heart, and cardiac rhythm skills. And I'm sure Victoria could speak to the same sort of combined approach in neurosarcoid. What I will say is that when sarcoidosis is more dangerous, we tend more often to want absolute proof from a biopsy, because we are talking about treatments that may have side effects, may be needed in the long term. And sarcoidosis does sometimes behave in odd ways. So you may be sure about the diagnosis you feel without a biopsy, but then what happens a year or 2 later, when the behavior is unusual, and then you regret that you don't have absolute proof of the diagnosis. But you're generally having to go away from those organs to other sites of sarcoid involvement. Again, we might or might not come back to this. Now we come to management. Again, a very big picture overview. First and foremost, not all patients need treatment, and I think at a rough estimate, perhaps only 40% of patients with sarcoidosis need treatment, and it's vital to avoid unnecessary treatment. It's terribly important because with steroids and other drugs in the long term, major problems can arise, and if treatment is unnecessary, then in that case, the treatment is much worse than the disease. Again, though, treatment decisions absolutely require information and a partnership discussion, and that can only work if it is spelled out exactly why treatment might be needed. And especially when decisions are a close call, and I'm afraid in life and medicine they often are, very careful thought about the risks if treatment is not used, and then the risks of treatment if it is used, and a balanced view at the end of that. So I said that more than half of sarcoid patients don't need treatment, so we must have clarity of thought, which is brief, can be said simply and understood simply, as to why treatment might be given. And I reached this conclusion just talking to patients over the years. What did they want from treatment in any condition? Well, one of 2 things or both: living longer and feeling better. And therefore, there are only 2 reasons to treat sarcoidosis. Firstly, if there's danger, and that might in a small group be death from sarcoidosis, but probably more often permanent disability because of worsening in your major organs. And then a completely different reason, unacceptable loss of quality of life, which can and often does happen when there is no danger. So obviously, if you take this view, you need to identify potential danger or danger already present. So disease that is now dangerous or is likely to become so if it is not treated and it worsens. So tests to identify risk are crucial, and I believe there is a question about that, and I can come back to it. But I just can't stress too often that unnecessary treatment is also dangerous. Unacceptable loss of quality of life, I believe, is more frequent than danger. And first and foremost, it's vital to establish that symptoms are truly due to sarcoidosis. A lot of people don't really have huge experience in sarcoidosis, and there can be an assumption, and I'm referring both to patients, family, and also to doctors, there can be an assumption that if sarcoidosis is there, all of the symptoms are due to sarcoidosis, and often expert evaluation has the benefit of separating out osteoarthritis if there are joint problems, atypical migraines, other causes of pain, and establishing that sarcoid therapy for those reasons in those patients is not a good idea. And then we're balancing if the issue is unacceptable loss of quality of life. We're balancing the risk of treatment causing a net loss of quality of life, which is not a therapeutic triumph, so avoiding punitive therapies. And this requires very careful discussion and negotiation. So it has to be established that the loss of quality of life is such that the patient really wants to try a therapy. It's often very important to give a short, sharp treatment just to establish whether life is transformed by sarcoid therapy. That's incredibly helpful because you have your goalposts defined at that point. So you can then find the minimum dose that meets somebody's needs. But I think detailed discussion really requires you to talk through different doses, different drugs. And I end up making 20 different deals with 50 different patients. Sometimes I give people a selection of low-dose steroid treatment and invite them to experiment a little, find out how low doses help them, find out whether those low doses are actually causing problems, and actually work this out. I could say an awful lot more about this, but I guess it's likely to come up in discussion. Treatment has to be holistic, not just drugs, but a discussion of many aspects of quality of life. And here it is so individual. So sometimes psychological counseling might be useful, sometimes rehab might be useful. And really talking through what matters to the patient, sorry about the typo, and their view of life quality. And people will decide what they want to try to fit with their values. Some people want to try yoga. I'm not a fan of exercise personally, but some people really value yoga and should be supported. And just talking through, look at your life and just examine what you might do based on what matters to you to make you feel happier in life, because often this has an impact on sarcoid activity. I don't think there's going to be time to go into this, but if I had to highlight the worst quality of life problem, it is fatigue. I didn't see a question about it. Vasilis, I can speak to this now as my final slide, or we might come back to it if there's time. What would you like me to do here?
I would say that you present your last slide, and then
okay,
if it is needed, we come back.
This is my last slide.
Yeah, please proceed.
Okay. I think it's the most important reason for major loss of quality of life, but it's often not accepted. People with fatigue look well sometimes. Family and doctors will say it's all in their head. Often there's brain fog. I have 3 key questions. I don't always ask them. The first question is, when I see somebody for the first time, if you could get rid of one problem that causes you to feel unwell, what would it be? And I think fatigue is top of the poll far and away. I think it about half of people with sarcoid symptoms or more will highlight fatigue plus or minus brain fog. I think it's very helpful to be very upfront and talk about two reasons for fatigue that are not sarcoid. One of them is loss of sleep, for example, if you've got painful joints. The other is what is called depression. I'm not sure that I like the word because I think unhappiness is something that you will have if you have a mysterious disorder that is ruining your life. The abnormal reaction is to be ecstatically happy about this, but I think you have to explore that. And it's best to do it on day one in a natural way, because otherwise you may be interpreted as making a judgment about somebody. I can't look at somebody on day one and know if they have unhappiness that is draining their energy. And then the other things you do are things that we might talk about later. I would highlight one of them: understanding your tiredness, understanding which people are energy drainers. Mothers-in-law often are. Understanding what things in your life drain your energy. Understanding whether on a good day you do too much and you pay a price for the next week. And giving yourself ways to control fatigue. I won't go into the other things because the discussion is so valuable that I think I should stop at this point.
Thank you, Athol. As always, a great presentation talking to the heart of things. So I think that you touched on it, but one of my first questions was whether you feel that a biopsy is needed for the diagnosis of sarcoidosis. And if you have a biopsy, when would you consider getting a second one? Because many patients have undergone a number of biopsies to confirm the diagnosis.
Well, let's do the first one first. You have to reach a conclusion on how likely sarcoidosis is before you do a biopsy. And I heard your discussion in the cardiac session. Broadly, we talk about definite diagnoses, and around the world for sarcoid, you'd say 95% likelihood is definite. Then you might make a confident, it's called a working diagnosis. In other words, there's no logic to any other treatment. And you're 70 to 90% likely, you can't be exact, or you may have a tentative diagnosis. Now, you've got two strategies. One of them is always to biopsy, or always to biopsy if you haven't hit the 95% level. The other is to decide against, but in that case, you'd better watch the situation closely and make sure that the course is typical of sarcoidosis. You are also influenced by how dangerous sarcoidosis appears to be, and whether you're going to need therapies, possibly high-dose therapies. And so you're going to have a conversation where you offer the patient the chance to take a view. And many people told that they're not in danger, it would be reasonable to observe, will decide that they do not wish to have a bronchoscopic procedure and undergo a biopsy. And many other people, even if you tell them it's 95% likely, will take the view that they must have a biopsy. And I think you've got to take the same approach when you think about repeating a biopsy. Again, you just run through that and you think about the implications of not making a diagnosis if the situation is more dangerous. I can't really talk to the second biopsy in greater detail without taking a very long time.
No, I think that this is helpful. My second question is, once you have diagnosed sarcoidosis, how far do you proceed in screening for organ involvement, like the heart?
Well, I think it is another key question on which I could speak for half an hour, but I won't. The dangerous scenarios are most often lungs and heart. neurological involvement is a lot less common, but is of course dangerous. And then there are much rarer dangerous situations. But in routine screening, you're going to use symptoms to guide you about the possibility of neurosarcoid, but you really must screen for danger in the lungs and the heart. And in the lungs, the combination of lung function tests, the severity of symptoms in case lung function tests are somehow misleading you, and often a CT scan allow you to risk stratify. In other words, below certain levels of lung function, you've got to be much more worried about the future. And I think that with the heart, you've discussed this, but there is a basic screening approach. ECG and symptoms suggestive of heart involvement. Be a bit careful if you've got lung disease as well, because you may be focusing on lung symptoms and you may not interpret symptoms that actually tell you there's cardiac involvement. If you've got bad lung disease, you're likely to have a racing pulse when you exercise, for example. So I think if you've got lung disease, I personally feel it's a very good idea to do an echocardiogram as well, as it will pick up stress on the pulmonary blood vessels, potential pulmonary hypertension, as well as screening what might be happening in the heart. But I think you've got to focus really on those two organs. And then there is a string of tests you should do at baseline, certain blood tests to identify liver involvement or occasionally kidney involvement, high calcium. So there's a string of blood tests that you do as well. Risk stratification, though, is centered on the heart and the lungs, and there isn't time to go into what thresholds you use in detail to know that somebody is at higher risk.
Thank you. That gives me the the perfect introduction for my third question. Now, you have two separate patients in front of you. One patient is a pulmonary sarcoid patient without any organ involvement, other organ involvement. And he is asking you the question, what is his prognosis going to be? And the second is a cardiac sarcoid patient, knowing that he has an advanced form of the disease. What is his prognosis going to be? What would your answers be?
Well, I think we have more robust information over a longer period of time about the lungs. And there's no doubt that there's a certain threshold of lung function above which, with the right approach, and that means watching the situation and being ready to intervene more strongly, establishing, if you do use treatment, that treatment is successful. But over a certain level with that approach, people have the same good life expectancy as those people who don't have major lung involvement and don't have other major organ involvement. So I think lung function thresholds are key. And there is a certain level where whatever you do, you may still be successful in individuals, but the chance of things ending badly, even with best treatment, does increase. But you get a sense of that from judging whether you're actually being successful in the shorter term with interventions. And you've also got to be careful if somebody is not far above the threshold, so that if they do get worse, they fall into this worse group. So for an individual, I'm able to make quite confident statements as to what the likely long-term outcome is going to be. Now, you asked about the heart, and by definition, if you have severe cardiac impairment, and I think that was your question, you are at increased risk. But there's no doubt, and here I'm straying into your topic, there's no doubt that with the right use of devices and with a proactive approach where you are being vigorous when you need to be, even in advanced disease, you can make a very major difference to the long-term outcome. And I think around the world, what we see is that survival now with this approach, survival has risen to a lot higher level in the long term than it used to be in the historical series. So part of it is taking precautions against life-threatening rhythm disturbance. It's best support of the heart. And what I would always say to somebody with advanced disease is that if things go well, and they may well, then a good long-term outcome is entirely possible.
Thank you very much. I will. I thought about a question that I haven't really prepared, but I think it's the right moment for this. You are the person that set up joint clinics in the UK by formulating a cardiac sarcoid clinic with cardiologists and a neurosarcoid clinic with neurologists, and you are one of the fathers of multidisciplinary approach in ILD. Now, why do you feel that multidisciplinary approach in diagnosis and management of sarcoidosis patients is more accurate?
That's a very complex question, and I will start with the combined clinics and what I learned. I didn't have the pleasure of working with Victoria because I left the combined clinic at the very moment she arrived, but I worked with a very skilled neurologist, and what I learned from that is how often diagnoses of neurosarcoid had been made, but the real problem wasn't neurosarcoid. So various pain syndromes that were not related to sarcoidosis, atypical migraines. So first of all, the combined approach where you have true expertise from another specialist helps hugely in working out whether symptoms are due to sarcoidosis or not. And then what you are doing with these combined approaches is bringing together neurological management and sarcoid management, cardiac management and sarcoid management. I certainly wouldn't trust me as a cardiologist to prescribe the right drugs to treat the heart. Then it comes to the general question of sitting around in a room with multiple skills to discuss diagnoses. And the thing is that it is like the blind men and the elephant, that old Indian parable, that each of you has a skill, can feel a certain part of the elephant, but you actually get much better answers if you put all these skills together. You get a much better sense of the diagnosis. And I think this applies equally to treatment. Understanding, for example, with skills in the room, the level of loss of cardiac function, the amount of damage, and the amount of inflammation. Understanding treatment priorities from each of the three specialists, working out which treatments are urgent, what order they should be given in, all of these things. You can't ask a sarcoid doctor with no cardiologist expertise to make those sorts of judgments. So, and I think the other thing is you've got disciplined minds who are used to debate, and just that fact, bringing them together, is to the advantage of patients. So somebody being skeptical, for example, in a multidisciplinary meeting is highly valuable. They're bringing a different view, they're debating, and they're really asking the question, could you be wrong about this? So I think that's all I would choose to say. Again, I could speak for half an hour to this.
Thank you very much. My next question comes down to treatment. And would you favor, if a patient needs treatment, to start a patient on steroid therapy, or would you consider giving a second-line therapy without steroids, and why?
Let's talk about danger first of all. The advantage of initial high-dose treatment, there are a number of advantages. Firstly, you find out very quickly in a dangerous situation whether the problem is responding. You often have to wait for quite a lot longer, and if the treatment isn't effective, you can lose valuable time in establishing that. If the treatment is effective quickly, you can bring the dose down very quickly. You can, if you use a high-dose steroid approach. I'm making this separation because I think the rationale is different for the two need-to-treat scenarios. So if there's danger, you need to find out as fast as possible that your treatment approach is likely to work. And then you need to decide as quickly as possible to get the dose down. And if you have got a quick response, you can do that much more safely. So that's my preference for steroid. And I acknowledge that there really aren't controlled trials comparing the steroid approach, which I think is used around the world for these common sense reasons, but there's no official comparison with other drugs. Now, when it's quality of life, I just have to stress making different deals with different people. You've got to take into account that your treatment may worsen quality of life. And you're not going to go for high doses in the longer term for sure. And people have strong views on steroid. And if there is no danger, I'm perfectly prepared to have my arm twisted and to start with a dose of methotrexate instead, or even hydroxychloroquine. The advantage again of steroid is you can find out quite quickly whether low doses do transform somebody's life, so you get quick guidance. But how you use the steroid, whether you do in fact use it first, I think is critically dependent on that discussion. I think we have two quite different medical paradigms, treating danger and treating quality of life. And you'd simply have to be hugely flexible treating quality of life issues.
Thank you very much. I have a last question because we are approaching to the end of the session. And as a sarcoidosis leader, I would like to ask you, how do you think that we can improve sarcoidosis patients' care, both from a level of reaching an earlier diagnosis? As you know, we have patients waiting for months and months to get a diagnosis, as well as providing significant amount of education and treatment options.
Yeah, it's a very complex question because we can talk about problems in a health service that apply to all diseases and certainly apply to sarcoid, and we can talk about the particular issues with sarcoidosis. First and foremost, you've got to think of sarcoidosis in order to diagnose it, and people aren't routinely going to sarcoid experts. So there's certainly ground to be made up in general awareness of sarcoidosis. It's not a vanishingly rare disease, let's face it, and one hopes that with the very proactive Sarcoid UK group and other groups, that there is a growing awareness of sarcoid and transmitting it to doctors, but how you actually, with a disease that is not common, make every doctor aware of it is difficult. I like to think that very often patients will read around their topic online and bring the suggestion to the doctor. A lot of my patients have raised sarcoidosis with their doctors, and that's been the initial step. And then there are a lot of good doctors out there who do recognize sarcoid. The second problem is getting to see a sarcoid expert, and sometimes you find that there is resistance to referring to a sarcoid expert. Sarcoid UK has a list of experts. Very interested to see their take on that, because really, if you have sarcoid, you have a right to see somebody who has expertise in sarcoidosis. but it's very difficult to legislate that from a sarcoid centre. Then there's really, I think you might want to ask me specifics at that point, getting to see an expert as quickly as possible. You'll get the diagnosis made of this doubt more quickly. Sometimes a lengthy diagnosis is unavoidable. Sometimes the disease is very mysterious. It's not top of the list. You go to a number of other diagnostic tests, and then it's identified as a long shot. But I think better education of doctors, closer links between Patient Sarcoid UK and doctors. And I think you can then break down the problems that arise in a health service. So when you're seeing a sarcoid doctor, as with all diseases, you will have blood tests on the day. That is our system. And it would obviously be ideal to have all results available before you see a doctor. You can then break down, and I think it's worth polling patients on their major frustrations, because that sort of information might lead to initiatives. Do you want to draw me out on anything else?
No, I think that is what I was heading to, and I think that's very important. Thank you very much. I personally want to thank you for everything that you have done for sarcoidosis patients, and looking forward for more such events, as I can see in the chat that everybody has requested. Thank you everyone for participating in this great day. We will have to move because we have sarcoid clinic actually, so we'll have to go there. Leo, do you want to have a closing point from your end?
Sure, yes, I know there's sarcoid clinics, so I'll keep it brief, but just to say thank you so much to all the speakers today. It really has been a fantastic event, and if any of the speakers are still on the call, please do have a look at the chat box, because there are some lovely messages coming in for you all. Thank you very much to Vasilis for working on us on this event. Quite a lot of work goes on behind the scenes organising events like this, so we really do appreciate all of your hard work and all of your help. Thank you as well to everyone who's watching. We really appreciate you being here. We hope you've learned a lot and we've been able to answer a lot of your questions. Sorry if we didn't get a chance to get to all of the questions. As always, time can be a bit tight, but we will save those questions and hopefully get to them at another event. And as Dr. Karanos said earlier, this is an annual event. So if you do have any feedback about things you think we do very well, or if there's anything you'd like to see more of at other events, please do let us know, and we will try and incorporate that as well. And finally, just to say, if you have enjoyed the event and you are able to, please do consider making a donation to Sarcoidosis UK. We would really appreciate it, and it allows us to continue doing our vital work. So thank you very much, everyone.